Thank you, Megan, and thank you for all the work that you've been doing on this conference. It's been a learning opportunity for us all, and I think it's gone very well, and mostly because of Megan's leadership. So thank you, Megan. We want to talk about the SMI Adviser, and we're very proud at NASMHPD to be working with the American Psychiatric Association on the SMI Adviser project. It's a really nice project. And two people that are here to talk about the project are Tristan Gorrindo and Amy Cohen. First, let me say something about Tristan. Tristan is a child psychiatrist who provides treatment for pediatric patients afflicted with mental illness. In particular, he has a focus on anxiety disorders and obsessive compulsive disorder. Dr. Gorrindo works as the Deputy Medical Director of the American Psychiatric Association in Washington, D.C. Dr. Cohen is the Associate Director, Implementation Scientist, and SMI Psychological Treatment Expert at the American Psychiatric Association. Dr. Cohen is a clinical psychologist with over 17 years of experience implementing and evaluating evidence-based services. Dr. Gorrindo, do you want to go ahead?
Thank you, Brian, for that great introduction. And I want to just extend my thanks before we get started to the entire NASMHPD team. You know, SMI Adviser 2.5 years ago was just an idea. And through our great partnership with organizations like NASMHPD, we've really created something very special over the last 2 years. And hopefully you have all heard about that along the journey over these last 2 years. But I just want to say thank you to Brian and Megan, Christy, David, the whole NASMHPD team for everything that you've done to make SMI Adviser a success. We wouldn't be here today without you. So thank you. We're going to do something just a little bit different today. I'm hoping you have all heard about SMI Adviser, or the Clinical Support System for Serious Mental Illness, as it's called, over the last few years. I'm not going to give you the kind of SMI Adviser 101 talk. We're going to do a slightly different talk today, which is not something you usually hear from grantees. We're going to be really introspective, and we're going to talk about what we've learned over the last 2 years, what some of the assumptions were that we made along the way, times when we got it right and times when we got it wrong, and the ways in which we've had to adapt and adjust as we go through the initiative. We just started year 3, 2 weeks ago. Out of our 5-year funding. And so this is a great time for us to be a little bit reflective and to share with you the things that we've learned and the ways in which we're going to grow and change moving forward. And I'm just so pleased to be co-presenting today with Amy Cohen, who's the project director on this. So let me just start by, of course, acknowledging our funder, SAMHSA. SMI Adviser, also known as the Clinical Support System for Serious Mental Illness, is a 5-year, $14.2 million initiative that's really focused on implementing evidence-based practice for the treatment of serious mental illness. And in the grant, we've really made made 4 primary commitments to what we consider the SMI Care Team. And that SMI Care Team is pretty broad. This was the SMI Care Team as we initially conceived it: physician, psychologist, nurse, peer specialist, family member, social worker. We've picked up others along the way. We're hearing more from the occupational therapists. We're hearing more from licensed counselors, marriage and family therapists. But to the entire SMI Care Team, we've really made 4 commitments. So the first is leveraging our incredible network of 30 content partners, NASMHPD being at the top of the list of our favorites. We're going to help clinicians implement evidence-based practice, and we're primarily going to do that through providing them with education on what the evidence-based practice says. The second thing we're really doing is providing direct consultation to clinicians so that any of the clinicians here on the SMI Care Team can reach out to us via email, via our consult system, and get connected with an expert of their same guild, as it were, to ask and answer a question about how to implement evidence-based practice within their specific context. And we'll talk more about these consultations in a moment. The third thing we're doing is really supporting the implementation of technology to enhance care. And a lot of this started out thinking about things like, how do we use smartphone apps? How do we use electronic medical records? I can tell you, since COVID arrived, it's a lot of how do we help providers implement telehealth and pivot quickly to be able to provide services that they traditionally done face-to-face remotely. And the fourth is using an ongoing and real-time data infrastructure to be able to know if we're on the right track or if we need to pivot. And a lot of what we're going to talk about today comes directly out of the data infrastructure. So everything we do is counted and measured and basically rolls up onto a dashboard that updates every morning so that we can see in real time, where are people going? What are they interested in? What are they telling us they need more of? Where are the gaps in care that are coming through on the PsycPro registry? Who's attending our programs? Who's not attending our programs? What kinds of formats are people looking to learn in? All of these things report up through our data infrastructure in real time so that we can adjust quickly to the needs of our learners. So as I mentioned, today's going to be a little different than your usual talk. We're gonna be reflective, and we're gonna look backwards so that we can look forwards. And you know what really prompted this was COVID. You know, for all of us on this call, our lives have changed since mid-March. The ways in which we work, the ways in which we socialize, it's all different now. And we had, you know, when this first started to happen, we had a sense that yes, you know, the community of SMI clinicians out there, they need some guidance. People are a little bit confused as to like what they should be doing. And so we just thought, could we bring people together to crowdsource some best practices? What are people doing around ACT teams or inpatient units? How are they supporting peer programs? And I can tell you that in our first webinar on telehealth delivery, we had like 4 times as many people participate in the live webinar as we had in any of our existing webinars. And so we knew in that moment that we had tapped into a vein, that there was a real hunger out there. And this became a model for us to then replicate around a number of things related to COVID. So, you know, whether it was tailoring ACT teams or adjusting clozapine protocols, COVID really was a spark for us to think about, we should be doing things a little bit differently because times are changing. And we heard from through our consult system, through our questions and answers on our webinars, all those kinds of things, that people were trying to figure out how do I maintain the fidelity of an evidence-based practice and implement it in this new world, right? So it's really that shift from dissemination to implementation. How do we help people take what the gold standard is and actually apply it in a new way? And that's always been the model of SMI Adviser, but it became particularly germane in the last 6 months when we really had to, when everyone was feeling that the ground had shifted underneath them. And so we use this as a nidus for us to really start thinking about, well, what other assumptions have we made around how providers want to learn, how they want to receive information, how they want to receive their consults, and can we adapt? And the answer was, we've made a lot of changes and adaptations, and we're going to share some of those with you today using kind of a question and assumption reality model. And we're going to walk you through some of those. So Amy, do you want to start with the, well, let me tell you just the last thing about our needs assessment. We have this, as I mentioned, underlying dashboards that allow us to see in real time where people are coming from, what topics they're interested in, how many learners. I can tell you just at a high level in the last 2 years, we've had about 25,000 unique clinicians participate in one of our activities. We've issued over 55,000 continuing education credits. We have participation from every SAMHSA region, every state, and the territories. And we can tell all of this in real time. We'll talk about who these people are more specifically, because that's one of the assumptions that we made in just a moment. So, Amy.
Good morning, everyone, or afternoon, based on where you are. So I want to walk you through a couple of the first few assumptions that we made and the information we gleaned from our data in order to understand how we needed to make adaptations to make it more appealing to the field. So first, we sort of assumed that our primary audience would be psychiatrists. And we thought we would have some limited representation from other disciplines. But the reality is that our audience is highly interprofessional. In fact, our data show, if you look here, I would just point out other is typically people who identify themselves as administrators, but then you'll see that our social workers, they rival the psychiatrists. And so we're really getting a really high amount of a mixture of our audience on our webinars, using our website, putting in consults. As Tristan already mentioned, we've had over 25,000 total learners so far in just 2 years, and it continues to rise. One of the things that this really prompted us, although we always thought of social workers as a big part of the team, there was a little bit of a resistance because we had so many continuing education that we wanted to offer. But we were really pushed in the beginning of year 2 to really go for accreditation with the social workers. Would I say that that was just something that came out of our hearts? Yes, but it was also really pushed by the data. There were messages on the boards from social workers like, hey, this is great stuff, but I'd like to get credits. So we did get accreditation late in study year 2. The first social work accredited webinar will be in September of this year. And then we also spent a good part of year 2 looking for a social worker who could join our clinical expert team. The clinical expert team of SMI Adviser is sort of the middle sort of think tank that represents all the disciplines plus counselors plus peer supports. And we found Shireen Khan, who's going to be joining us. She's from Thresholds in Chicago, one of the largest groups serving those with SMI in the Illinois region. They have many sites and serve, they have like 1,600 professionals who work there. So she's joined our team just 2 weeks ago and is helping us really guide us from the social work perspective. So we also made an assumption that our education would primarily come and be driven by needs assessments. And this is not to say that needs assessments have not been critical. They were certainly very critical at the beginning to get us started. But we've also realized that there's a lot of value in just-in-time learning on current needs that are high values to clinicians. And again, like Tristan said, this really was stoked by COVID when people were really writing us and saying, we need more on telehealth. We need something to help our clients know how to engage in telehealth. And so we are now using both needs assessments that are planned, plus just-in-time needs and being reactive to those. So in doing so, we've also carved out room in our schedule to just be responsive to hot topics. Before, and I think this is typical when you first start a grant, you want everything sort of planned out. It's like, we got to make sure all of our bases are covered. Let's keep going back to the grant and the initiative and making sure we're checking every box. Now we've said we're confident enough. Let's leave room for hot topics so that we can slot things in and be really flexible and pivot. And that's really paid off for us, and hopefully I think for our audience as well. I would say the response to these hot topics has been incredible. So here are just 3 that we offered in year 2 of the grant: telepsychiatry in the area of COVID and mental health, caring for the public and for ourselves. And then also how to tailor ACT teams, group homes, delivery to those groups. And we were stunned when we, for example, did the one about caring for the public and for ourselves. Over 6,500 individuals actually logged on and were part of that conversation. And so we realized, wow, this is what we thought we were doing before, the kind of audience we were getting before, we thought was incredible. No, this hot topics and being responsive is really showing us that we're drawing and tapping into something important. So another thing that we did to be responsive, as I mentioned, there were comments and there were consults written in like, we really need help with X, Y, or Z. And so here's just two examples of de novo resources that we developed. One on the right is how to prepare for a video appointment with your mental health clinician, really low level reading level, what to do before the appointment, what to do the morning of the appointment, how to start the appointment, and really just takes them through each step. Even things like have a pad of paper, make sure you have your glasses with you, maybe weigh yourself that morning, just all of the little things that will help them have a much more efficient and productive meeting with their clinical care team online. On the left, this just came out about 3 weeks ago and has jumped to the top 3 of our resources being accessed, which is tips for telehealth billing during COVID-19 pandemic. And we really envision this as something someone would print out, and put on their wall. And it tells them all of the billing codes for all the different kinds of mental health visits they may be having through telehealth. So I think these have been, again, we're realizing we're tapping into something here when we get the kind of responses. So we've liked that.
Another one of our assumptions was that we would primarily be using 1-hour webinars, that is how people would want to learn, that they would block off on their calendars every Thursday at 2 p.m. Eastern time to sit down and participate in a webinar series, and that over the course of the year, they would participate in 40, 50 webinars and become even more expert in caring for those with serious mental illness. But what we found was that we had a huge amount of uptake of our alternative shorter learning formats. And that's actually driven us to create more kind of atypical ways into knowledge. So for example, for clozapine and long-acting injectables, we've actually created a separate community through our LAI Clozapine Center of Excellence, which includes things like a listserv, where they're just sharing tips that go out every month or every few weeks around common clozapine challenges, common long-acting injectable questions. Starting this month, we're launching a new clozapine long-acting injectable faculty-led virtual gathering, where basically there will be a topic announced the day before. Everyone on the listserv will receive the invite, and then people are just basically welcome to dial in. And the idea here is to give people an opportunity to talk in the gray. The topics that are going to be selected each month are going to be things where there aren't a clear answer. Like during COVID right now, for example, how are people implementing mobile ANC testing? And how has that worked? Are you able to bill for it? How did you partner with labs to do it? How are you? All those kinds of logistical questions where there isn't a best practice yet, but we felt like we needed to create a place where people kind of get together to talk about these things. We're also looking at creating shorter format webinars. So we think about education in terms of bites, snacks, and meals. Right? We think about our meals really being our 1-hour webinars like we're doing here today, but sometimes people just want a snack. They just want 20 minutes, something really brief, or they want a 5-minute little article blurb that they can read. Occasionally we'll offer the big buffet, the 2-day conference or the 5-day conference. But we need to be thinking differently about how people want to engage with information as well. And for those of you who've poked around the SMI Adviser website, we have an extensive knowledge base, which is kind of a frequently asked questions for serious mental illness. We now have over 1,000 resources for clinicians and several hundred geared towards family members and patients. And we're now looking at ways to start embedding video in some of those answer cards to bring some of the content to life a bit more. The other assumption we made was that we thought, people largely will want to stay in their lane. Psychiatrists will want to hear about psychopharmacology. Psychologists will really want to hear about therapy. Social workers will really want to hear about kind of case management. And we couldn't be more wrong. What we see is huge interprofessional engagement across all of our content. It's not to say that it's equal for every webinar we do, but we do see broad participation from our attendees on all of our webinars in particular. These are our most highly participated in webinars, and you can see that they have actually a pretty broad interprofessional slant to them. So burnout, we know, this is not, just a condition that afflicts one provider type and not the others. This is a challenge for all mental health clinicians. CBT for psychosis, even if you're not a therapist, everybody is thinking about how can I incorporate basics of CBT in my care. Criminal justice involvement. Deb Pinels did a 3-part series for us, which was hugely popular. And starting with the very basics, like what happens when my patient is arrested? Like what is their experience? Where do they go? What do all these, legal terms mean? Physical health has been a big part, largely led by Ben Druss, and has kind of helped us look a lot at the interface between physical and mental health. Psychiatric advance directives, we're going to talk a lot more about that in a minute, has been a huge emphasis of year 2 for SMI Adviser. And then suicide prevention. We've started doing some work with SPRC and APA kind of separately is part of the new SPRC, which is going to be starting in September as well. And so we'll see a lot more of the interplay between suicide and risk assessment and serious mental illness in the year to come through SMI Adviser. We've also really focused on developing tools that serve the entire clinical team. So I hope all of you have the SMI Adviser app downloaded on your iPhone or Android device, available now in your local app store. It includes access not only to all of our education and those thousands of knowledge base articles, but we've included in there some measurement-based care tools like the PHQ-9 and DAST and some anxiety measures, things that we hope frontline clinicians will use every day. We are excited to be releasing, still a little bit in a soft launch. A formal launch is coming in the coming weeks from SAMHSA, but a new app really focused on crisis planning and psychiatric advance directives. So it's called My Mental Health Crisis Plan. It facilitates patients working with their clinical team in developing an interactive crisis plan via an app on their phone. And then once they complete their crisis plan, they actually have the ability to turn it into a psychiatric advance directive if they meet their state requirements. In some states, it's as simple as actually just signing on your device, on your tablet. In other states, the legislation there is more complicated and requires notaries and those kinds of things. But we really built all those sharing tools right into the app. So please keep your eye out for a big announcement on that from SAMHSA in the coming weeks. Another assumption was that there would be equal uptake of the learning modalities for each topic, that we would have psychopharm and psychotherapy would have equal uptake in webinars. But it turns out that some topics tend to lean preferentially towards certain modalities. Psychopharmacology, for example, is at the extremes, right? So we see people who are interested in psychopharmacology going towards the snacks and the bites, the really short information. They want an answer. What do I do with that norclozapine level again, right? I don't need an hour webinar. I just need to know, how do I interpret that result? And then we also see them gravitating towards our virtual learning collaboratives. These are 12-week in-depth engagements, faculty-led, team-based. They're expected to work on a project. How do I build a clozapine clinic in my program? Or how do I implement measurement-based care? Or how do I incorporate physical health into my program? So we see, in that one example, people interested in psychopharmacology heading towards these very divergent learning formats. And we think that's an expression of people's needs in that moment. Sometimes you need that point of care, just-in-time learning, and sometimes you really want to take that expert-led deep dive to really try to change your program and change your approach. And so we've also really started to think more about that as well. And here are just some examples of those virtual learning collaboratives. Those are those 8, 10, or 12-week engagements. Our most popular ones have been focused on pharmacology, schizophrenia, and clozapine. And down at the bottom here, these are those snacks and bites, those knowledge base answer cards, as we call them. These are just kind of a paragraph summary of an evidence-based approach. And our top ones here, what are clinical considerations for giving LAIs during COVID-19? What should clinicians know about haldol decanoate? And how do I interpret clozapine and norclozapine blood and serum levels, and what do they mean?
So when we first started, I think when we were writing the grant, we thought we would be the umbrella, that we would be the umbrella for all information sort of around SMI, around caring for those with SMI. And in many ways, the knowledge base has been a place that has been umbrella. We take in resources from groups like this and a bunch of other resources that are submitted. We vet them all by 2 experts before they're chosen to be included in the knowledge base. And as we said, we have over 1,000 now. But we also realize it's been very important to be part of this puzzle of all of us who are together trying to improve care for this population and to also help our clinicians. So one example of that that I can sort of point to was last year before our IPS conference at APA, we had a 1-day pre-conference where we partnered with NIMH and NAMI and PEPNet to deliver a 1-day conference, but really an interactive point for those of us treating individuals with first episode psychosis. And we were really proud of that work, and we had a lot of individuals who came, but maybe there were some limits in the sense that it was attached to IPS, and we're actually sort of secretly excited that this year we're going to be able to offer it as a virtual collaborative. And the reason we're sort of super excited about it is that we believe it's going to bring in a lot more disciplines, some disciplines who wouldn't usually be able to travel to conferences. And we're really hoping to really pull in the sort of teams. And we've developed a program committee that really represents those who are treating individuals with first episode psychosis, young trainees, older, more established people from all around the country. We're going to be offering that probably in November. The date isn't set yet, but look for something coming, and it'll be a 2 half-day conference. So we're looking forward to doing that again this next year. As Tristan sort of alluded to, we assumed that we would be mostly focused on disseminating, that we would be a repository of sort of education and resources. But what we've realized is that people then, as soon as they get the resource, they're like, but tell me how to actually do it. Okay, that's great. And I learned that in school, and I've read the articles in psych services, but like, that's not how it's really going to work. That's not how our team is really made. That's not really our audience. And so we've really spent a lot of time thinking about implementation. And one of the things that SMI Adviser offers, in addition to the very short consults, the sort of snack consults where someone writes in about a specific level, also sites or communities can apply to be an implementation site and get intensive consultation to make a change. And so that is where we really get to dig in and help with implementation, doing evaluation of what's going on there, where are the gaps, what could really work here, let's try it, let's look at it, and then let's also evaluate if we need to make changes or sustain it. So that's been a big part of that. As Tristan also mentioned, we've been doing much more of this horizontal technical assistance, where it's not an expert talking to the audience, but rather the audience talking amongst themselves and us being just a facilitator. And this COVID webinar that I talked about earlier about ACT teams, group homes, and supportive housing was just that. It was a town hall. And we had 3 individuals from the community who we had worked with, and just asked them to come forward and represent their disciplines and what they'd been doing. And it was a really, really great experience for all of us. Tristan mentioned the fact that our centers of excellence, we have 1 in clozapine and 1 in long-acting injectables, have a listserv. It's extremely active. People are writing on it every day. And you can see here that we've really grown in subscribers. And out of this growth is what came this virtual forum that we're developing, which will start in August, where we're going to have people can drop into it whenever they want. We're going to take a hot topic that's been discussed on the listserv or another hot topic that's come up that will allow for people to share amongst themselves. So I think the listserv is a place of, drop in, find out, and also these virtual forums will be the same. So again, we thought people would be flooding us on our consultation site, that we would probably be overwhelmed answering consults all day. That's not exactly what's happened. What we've learned is that clinicians look for consultation in a variety of ways. It is certainly picked up since people have been stay at home because they can't go down to their colleague's office anymore like they used to be able to. So we are getting more consults, but we're also noticing that we had to, for example, increase the question and answer time on our webinars so that more people could ask questions. We've opened up these implementation sites so communities can get consultation. So we've really been thinking about it in a lot of different ways. Again, I won't go into this too much. We've had a lot of registrations for our webinars, and that's been still a robust way for people to learn. So the implementation sites have been a really rewarding place for us to work. We thought that they would just apply, they would be accepted, and they would be ready to go. Well, COVID was a bump in the road. And we've had to really not only adapt what we thought would be the work that we would do with them, but also how we work with them. It's much more on their schedule. There's sort of a push and pull. There's times when they're really active and then they may settle for a little while and then be active again. So we're still looking for implementation sites. We can handle several a year. So if you are someone who knows of a place that would be ripe for making some larger changes or larger amount of consultation, we're happy to hear from them. Again, everything's free. We'd love to hear from you. And I just wanted to also, I put these in here, we put these in here just to show you an example of the kinds of things that sites are working on, these implementation sites. So for example, one of the sites wanted us to make a form for safety considerations for home visits. What should I be thinking about before I go? What should I be thinking about when I'm there? How should I communicate with my colleagues about it? Another site, one of our Indian health sites said, we've got a lot of people who are seeing clients who are BA or MA level, haven't seen a lot of people with psychotic symptoms, and clients often come one time for 20 minutes. We would like to be able to give them something that they could do at home. They could find a support at home. So we made up a sheet on just coping with psychotic symptoms. Here are 10 things you could do or 8 things you could do when something arises, a voice that you haven't heard before, or you're feeling something or any kind of delusion. And the counselors are using this in session and then giving it as a take home. So those are just 2 examples of implementation site projects that we're working on. I think you're on mute.
Thank you. I just want to close out by sharing with you some data from our year 2 needs assessment that has also helped inform how we're thinking about next year. And particularly, these are data that NASMHPD and NRI helped to collect for us. So we use a standardized taxonomy, which comes out of more or less out of the ISMIC report from several years ago. That basically covers all the domains of serious mental illness, right? And we use that as our kind of foundational taxonomy where every activity, every consult, every educational module, every engagement we're part of gets tagged back to that taxonomy so that we can see, are we overrepresented in some areas, not in other areas? Are people requesting more in some areas and less in other areas? And so part of the projects that NASMHPD did for us last year was to go through our own taxonomy. What are the resources we have available? And to identify areas where we had not produced enough information, to identify areas where we had maybe underrepresented resources. And so these are some of the things that they had identified and some of the things that we're going to be focusing on this year. More information on manualized psychotherapies. We actually had a really great call with AAAP earlier this week, the addiction psychiatry folks, around looking at some structured interventions for those with comorbid substance use disorders in SMI. They've identified high utilization as being another underrepresented area. We need to focus more on ACT teams, and we need to focus more on LGBTQ populations as part of the work that we're doing to make sure that we're covering the entire waterfront of SMI. And we're also asking our partners and our audiences, when we talk to folks like you, we want to hear from you, and as terms of what you think the field needs more of. And we're going to do some polling questions in a few moments to get a little bit of a sense of this, and maybe look at the chat. But we welcome you that if there's a resource that you can't find or you think would be useful, to just reach out to us. Submit a consult. Consults don't have to be big formal engagements. You know, I have a 60-year-old male with a history of schizophrenia and I don't know what to do with X, Y, and Z. It can be as simple as some of the questions that that folks have reached out to us from the implementation sites. Hey, do you guys have any resources that I could give to my staff that are just starting with home visits that will help them feel a little bit more safe or a little bit more aware before they step into a client's home? So we encourage you to reach out, to engage us, so that, again, we can adjust and adapt to the needs of the broader community. And, you know, we hope that you'll share this information all the way down. You know, we know that many of you oversee huge programs with hundreds and thousands of clinicians that you oversee. You know, and we want to hear from the front lines too, from the occupational therapist on the floor, from the social worker doing the case management. We hope that you'll really help push down through your channels the resources and the opportunities that we're making available through SMI Adviser. And the NASMHPD newsletter, there's always a little bit of a spotlight there on SMI Adviser. And so that's one way you can kind of stay aware of the things that we're working on. But please, we hope that you'll help your teams be better by just making them more aware of us as a potential resource to them. And I guess that takes us to collaboration and the things that we hope that you can partner with us on. You know, if you're looking to share information about SMI Adviser with your teams, with your programs, we've created a whole bunch of fact sheets, flyers, social media posts, whatever you want, at smiadviser.org/toolkit. You can just download it or send the link, but it's kind of ready-made for sharing with clinicians about what's the value we have to offer. We hope that, even though I said, you know, we thought everybody would be doing weekly grand rounds with us, and that's not exactly true. We hope that people will think about that many of you, you know, we know from our workforce work that providing accredited education is a great workforce retention strategy. And everything we offer is for free. We're, as Amy alluded to, we're adding social work accreditation to our psychology accreditation, our nursing accreditation, and our physician accreditation. And we hope that you'll let folks know that there are live and recorded educational opportunities available to them every week. And I should say, at this point, the library of accredited activities we have for people to engage in on demand is well over 100 at this point. And so folks, you know, you let us help you as part of your workforce retention strategy by saying, here's a great professional development resource that you can use, and feel comfortable knowing that we're going to be offering evidence-based approaches that are focused on real-world implementation as part of that. And of course, we'd love you to encourage your clinicians to submit consults, whether they're little consults or big consults. We want to hear from you and your programs and your clinicians as to how we can help them implement evidence-based care. This is our website, smiadviser.org, and Amy and my email addresses are both listed here. And we would love to hear from you if you guys have thoughts or questions. We have some time set aside to do some interactive polling, but I'm wondering, Amy, should we take a few minutes to just see if there are any questions in
I think that would be
chat?
great if there are any questions now. Yeah.
Yeah, so Tristan and Amy, thank you. That was very good. I wanted to take a few seconds to thank Christy Malik for her work on this, as well as Stuart Gordon and Dave Shern, their NASHPD staff that's worked hard with Tristan and Amy and their staff. Also, I wanted to just let people know that we did a paper on clozapine about 5 years ago, 4 or 5 years ago. And we had a listserv on clozapine. And it's really nice because we ended up taking that effort and folding it into the SMI Adviser effort. And many of the people, almost all the people that were on our listserv folded into the SMI Adviser listserv. And we were very happy working with Dr. Alex Young, now with Dr. Rob Cotes, on both the clozapine and long-acting injectable landing pages. And it's really been a nice effort. So wanted to thank you for that. Had a question about the health equity and disparities issue. One of the big gaps that's been shown as a result of COVID is related to lack of health equity and major disparities in the minority population. And I wonder if you would say a few words about that and how SMI Adviser may be able to help respond to that.
I'll go ahead and start, Amy. Feel free to chime in. You know, it is such a challenge. And, you know, even though the spotlight has been shown very directly through COVID on issues of health equity and structural racism and kind of the broader context more recently, these are longstanding problems. And we have committed to, in all of our educational offerings, requiring our faculty really talk about, even before the activity is accredited and evaluated, to talking about how they're addressing issues related to diversity and health equity as part of their program. We have some specific resources that are really focused directly on specific populations, but we also feel like it's important that it's part of our underlying fabric, that it's woven into every activity that we do. And so particularly in our webinars, we made this, I would say, much more deliberate in December, January of this year, that we asked all of our faculty, required all of our faculty to really speak to these issues within their webinars in particular. But it is something that we're paying more attention to, and you know, that I think we're hearing, you know, Brian, as you mentioned, a louder cry from the field, as it were, for people to have a better understanding of health equity issues. Amy, is there anything that you wanted to add to that?
I would just say that this has also been a big push on this first episode psychosis virtual conference we're going to have in November, is really considering those issues as an overall theme, similar to the theme that you're doing, that we just feel like that is something that has to be addressed, both in the content, in the program committee, in the speakers, in the way that we're doing the marketing. We're just really, that's a blanket over the whole effort. So I think we're trying to do our best.
We appreciate that. And if there's anything we can do to partner with you on these issues, this is a priority for NASHPD. So now if you want to move ahead, Tristan, Amy, to talk about some of the resources and tools that may be available for frontline clinicians caring for individuals with SMI. So, thank you.
Yeah, thank you, Brian. So I think we had decided we were going to keep this a little less structured. We have some polling questions, and we thought we would, based on the polling questions, kind of speak to some of the things that we're doing or that the field may need. So I'm wondering if Amy, our amazing producer, could go ahead and put up the first poll. So the question is, are you providing accredited professional development, CE, CEU, CME, for staff in the programs or hospitals you oversee? And your choices are yes or no. Hopefully that was a pretty straightforward question. So people don't need a lot of time to answer it. Amy, do you want to go ahead and put up the results, please?
I still have results coming in.
Oh, all right.
If you'll hang on just about 30 more seconds.
It was a more complicated question than I thought.
The system takes a moment to catch up.
All right, interesting. So a little more than half are providing CE and CEUs, and CE, CEU, CMEs. CPD seems to be the newest acronym added to the mix. So just it's ever ending, but are providing accredited education as part of the program. Amy, do you want to talk a little bit about this and things we're doing at SMI Adviser that we might be able to help the 41% who say no?
Right. So one thing, and I mean, again, we have an on-demand catalog, which we've mentioned multiple times in the last 45 minutes, but one thing that's come up that I thought has been an interesting use is that we've heard from a number of training programs where they're choosing an on-demand webinar from our catalog. They're sort of assigning it, instead of having a journal club that is a article, they're choosing a webinar. And they're saying, we're going to talk about this next week on Thursday. Everybody log on here and at your convenience, watch this, and we'll discuss it next Thursday. So this idea of using the on-demand catalog as a training mechanism, we have found that has been interesting. We've had a couple people write in and say, is that okay to use it that way? And we're like, that sounds fantastic. So just an idea. We have, again, nursing, we have psychology CEs, we have CMEs and social works coming, and we have a catalog that can be searched by keywords. We also have grouping under different topics. If it's easier for you, just need to sort of generate an idea. But that's something I would encourage. I know, Tristan, if you have other ideas, but I thought that was a really creative way to use the on-demand catalog.
I think that's a great example. The other thing I would encourage folks to do is encourage your staff to sign up for our newsletter. I'm going to go ahead and just show our website here quickly. Here's our website, smiadviser.org. And right down at the footer in every page is the ability to join the newsletter. It's 4 questions. And in doing that, we'll email you every month a list of all the upcoming webinars for the month, learning collaboratives, latest resources. So in some ways, it's a ready-made professional development program. We're going to cover all the aspects listed in that ISMIC report and that table 1 there, and over the course of a year or 2. So it's a really broad-based approach to SMI. So, visit smiadviser.org, sign up for the newsletter at the bottom. You go to Clinicians and then click on Education Catalog. You'll see the hundreds of activities that are currently available. So here are some examples of ones that are currently available. All right, why don't we try another polling question? Which disciplines, from your perspective, are most in need of additional training or support? And you get to pick one. So if you had, a genie who's going to grant you one educational wish to provide additional training or support, and you could only bestow it upon one clinician type, what would you pick? Your choices are psychiatrist, physician non-psychiatrist, so this would be primary care or other kind of consulting physicians, your nurses, your psychologists, social workers, counselors, peer specialists. Which would you pick? While the results are coming in, I'll just say, we're creating education for all of them. So we're hoping that you can help kind of nudge us in one direction or another. It's another data point that we'll use in kind of shaping the educational program. As I mentioned earlier, we're just starting year 3. And so we're creating our kind of scripted educational plan for the year with some holes in there for the hot topics as they pop up.
Interesting.
Interesting. Amy,
Yeah,
let
me talk through this a little bit. So looks like our top groups are peer specialists, counselors, and physician non-psychiatrists. Psychologists, I guess we're great. We need no help. Social workers are there, psychiatrists less so. And so what I'm feeling here is the groups that maybe have less exposure through their training programs to those with SMI, meaning physician non-psychiatrists, peer specialists, counselors, are really wanting more. You're really wanting more guidance for them. I find it fascinating because it's what I'm hearing when I go to these implementation sites. They're really struggling with those groups that are either less familiar to the team, like the peer specialists or the physician non-psychiatrists. They want to know how to work with them. We know that they have a lot to offer. We don't know how to connect with them. We don't know how to talk with them. And then also the counselors, who are typically either BA or MA level, who may not have been exposed to the groups with the more serious mental illness. And so I really appreciate that. And we really have been trying to think a lot about how we can reach those folks, what kinds of sort of 101 foundational educational items we need. I know that one of our sites, they have a training collaborative in New Mexico, a behavioral health collaborative of several different services provided. And they said to us, listen, we just need some foundational. So we put together with the National and Hispanic MHTTC plus SMI Adviser a list of trainings, and we sort of group them, like here's criminal justice involvement, here's some foundational ones, here are some things about stigma, here are some involvement about trauma, here's some easy measurement ones, just to give them sort of a catalog, a personalized catalog for their site to help them bring everybody up to the same level. So I appreciate this idea that we're trying to bring everybody up to have a shared vocabulary and things that we're looking at together through the same lens. And I would say also in terms of the physician non-psychiatrists, we've really put together some webinars that talk to both sides of that communication. So how do you talk to the physicians, non-psychiatrists, and what are some of the basic things they need to know? How do you talk back and forth about side effects, about a treatment plan? How do you communicate about the family? And so we are thinking about that as well, and realize that that is something the field wants. But it's always great to be the reinforcement from this group that we should keep going with that.
Why don't we put up the last polling question?
Yeah, that's good. So this one is, yeah, go ahead.
You go for it.
Are you requiring psychiatric advance directives in your programs or hospitals? Yes, it's going well. Yes, we are, but we're struggling to implement. Or no, we don't require psychiatric advance directives. Let us know. Give us a sense of the climate out there for psychiatric advance directives. As we mentioned at SMI Adviser, we're about to do a public launch of our psychiatric advance directives mobile app. We are going to NASMHPD has really helped us find a few sites where we can begin to test the Psychiatric Advance Directives app plus a facilitator guide. So here are our responses. Wonderful, exactly what I wanted to see. Either we're doing it and we're struggling, or we don't require it. So, and And somebody wrote into the chat, we're doing it, but it's not required. So I appreciate that. That's an even bigger lift. So let's talk for a minute, Tristan, about our Psychiatric Advance Directive app. I know you introduced it in your talk. What I would say about it is we recognize that there are a lot of barriers to completing psychiatric advance directives. But we also know that a lot of people are talking about crisis plans, that a lot of people are talking about it as part of outpatient treatment, about, during, sort of day treatment or partial hospitalization as well as hospitalization. And the way we've been thinking about it is really a crisis plan plus. Right? So the app really allows you to make a crisis plan. And even if you don't take the final step to sign it or get the witness to sign it or to do anything like that, you still have something that's very, very valuable. The process of making it is valuable and the having it is valuable. And so we are asking a few sites, we're working with 4 sites over the next couple weeks to really test it. And we've developed a very short facilitator guide with a lot of little facts and FAQs about how to motivate someone to participate in thinking about a crisis plan and psychiatric advance directive, why it's important. And really going to try it out with some people. Give us feedback. It took way too long. The person said this, the app was hard here. But also, hey, this actually gave me a framework. We're hoping we're going to hear that as well. So Tristan, what else would you like to share about the PAD app?
I think we've started to, and I have to say, even though we've developed this app and SAMHSA is going to be helping launch it next month, that we're standing on years of effort by Marvin Schwartz, the folks at Duke, the SAMHSA toolkit that came out last summer, and we're really just trying to operationalize it in a way that we think will be more in line with the way in which our patients and our clinicians live these days. That everything's on their phone. They want it to be simple. They want it to be digestible. And so we've really tried to, in some ways, simplify the process through the technology. But one of the barriers that we keep hearing from clinicians is their fear of PADs, which is if a patient shows up in my emergency room and they have a psychiatric advance directive, which says, I don't ever want restraints, or I don't ever want medications, or I only want to be hospitalized at this hospital, that somehow their hands are tied. And you have to remember, psychiatric advance directive is just like any other advance directive, whether it's getting chest compressions or intubation or resuscitation. If you're medically ill, it's still ultimately the team's decision. But an advance directive says, all things being equal, if I had a voice in my own care in this moment, my preference would be X. And that's really the needle we're trying to thread through this. And so we'd welcome your ideas around those of you who have had some success in implementing psychiatric advance directives, how you've helped shift the culture within institutions around not fearing the psychiatric advance directive. JACO had introduced earlier this year for its behavioral health accredited institutions a requirement that they give every inpatient information on a psychiatric advance directive. We're trying to replace give information with tell them to go download the SMI Adviser app, because we think we can probably do it better than handing them a stack of paper around psychiatric advance directives. But there is this other culture piece that we're working against as well. And so we'd really welcome your thoughts, particularly those of you who've been successful in this, and how you've helped educate your staff and your adapted processes for intakes and those kinds of things to ask patients and look for psychiatric advance directives. Because I think that's even with the easiest technology, that's a hill we still have yet to truly climb and conquer. And that's our next big step, I would say, as we move forward. With that, I think, Brian, we're right at time. So I'll turn it back over to you.
Thank you, and thank you for an excellent presentation. And we really encourage everyone to download the SMI Adviser app and play around with it, and also give feedback. I mean, I think that Tristan and Amy and their team, they're really trying to improve the app. And so if there are things you think they could benefit from, please give them feedback. So thank you. And now we want to switch over to legal issues and crisis services.